We'd like to welcome everyone to this meeting of the Provo Municipal Council work session. Today is Tuesday, August 3rd. The time is 2:04 p.m. Meetings of the Municipal Council are now being held in hybrid fashion. Members of the public may continue to view council meeting on YouTube and Facebook, or they may attend in person in the council chamber at the Provo City Center. The mayor, councilors, city staff, and any presenters are participating in the council chamber or by using Zoom webinar or calling in. The coronavirus pandemic is not yet over, but vaccines are available. We encourage everyone who is eligible to get vaccinated. We encourage all people to protect themselves and others by following the protocols set by the CDC and our state and local health departments. Stay safe and be kind. This meeting is being broadcast live on the web and on the Provo City Council YouTube channel, where it will also be available for on-demand viewing. I remind participants to mute your microphone when not speaking so as to minimize the potential for background noises and conversation to be picked up, recorded, and broadcast for all to hear. We have all council members participating today. All are here present except for George Hanley, who is participating by phone. We have Mayor and Chief Administrative Officer Wayne Parker and City Attorney Brian Jones here with us, as well as members of council administrative staff. We would also like to officially welcome Malia Daly, who is a new policy analyst for the council who will begin work this week. The opening prayer today will be provided by Councilor Shannon Ellsworth.
Our dear kind Father in heaven, we are grateful for this day and this opportunity to serve together. We're thankful for our beautiful city, thankful for all the citizens who contribute and volunteer and improve Provo in different ways. We're especially grateful for the staff and all the employees at Provo City, firefighters, police officers, those who risk their lives to protect us. Father in heaven, we pray that thou will bless us, that we can make the best possible decisions, that we can be wise stewards, and that we can be compassionate neighbors. And we say this in the name of Jesus Christ. Amen.
Amen. Thank you. Although this is a public meeting, only the presenters and those invited by the council may speak or ask questions unless otherwise invited by the chair. Please wait to speak until called upon by the council chair. Remember to mute and unmute your microphone as needed. First item is that we propose to approve the minutes from the July 20th, 2021 work meeting. Are there any objections or requested changes? Seeing none, I'll declare those minutes approved by unanimous consent. First item of business is a presentation regarding COVID-19 vaccines from Utah Valley Hospital. And this will be presented by Dr. Larry Ford, infectious disease coordinator, or I'm not sure what the rest of that title is, from that department anyway, and Kyle Hansen, Utah Valley Hospital Administrator. We very much appreciate you being with us, and we are concerned about what we're seeing in the pandemic, as I'm sure that you are, and are anxious to learn more about what you have to say in this regard. So please.
No, we sent in, I think, 2 presentations. I don't know if they were put together or if there's a way to maybe fast forward a few slides to the presentation that has, there we go, perfect. I'm only going to share a few slides here. Let me start just by introducing myself. I'm Kyle Hansen. I'm the administrator at Utah Valley Hospital. I know I've been to some of your meetings in the past and virtually. City leaders, we always are grateful for the work you do and protecting the city that we work in and live in, and appreciate the energy and time you spend And excited to share just kind of some updates. Obviously, misinformation has been a considerable challenge over the last 18 months. So any opportunity we get to come and speak to what's really going on, what we're experiencing at the hospital is certainly valuable to us, and we hope valuable to you. Wanted to just take the opportunity to recognize the healthcare workers we have working in our hospital. The last 18 months has been unbelievably challenging in our hospital, and we have some of the most amazing citizens and individuals who work in our facility, who are at times risking their lives, but are just some of the most dedicated individuals you'll ever meet, and continue to care for our community no matter what that means or what that looks like. So wanted to just open with that. If we could go to the next slide. Let me just share with you some data from this year in regards to what we've seen with some of our COVID admissions and statistics. And then I think Dr. Ford will share more detail around the vaccine. Last year in 2020, we had just over 1,300 admissions to the hospital, patients admitted to our hospital with COVID. About 109 of those were fatalities, unfortunately. So about an 8% mortality rate of the admissions from last year. And as you look at kind of the month by month data that we have up here relative to admissions, as all of you know, we saw a bigger surge earlier this year with impacts to the hospital. We were sort of in crisis staffing mode for a number of months. You can see in January, we had 277 admissions, almost a death every day, a COVID death every day in January in our hospital during that month. And for the most part, you know, the mortality percentage, even as the volumes have changed, has hovered kind of between, 5 to 10%. But you can see our total admissions came down considerably in March and April as the vaccine started to have an uptick. And just in the last 2 months, we're starting to see the hospitalization numbers go up, which I know you're aware of from state data and other information that's being shared. This is starting to have a considerable impact on us. And I'll show you in a second here some data that explains some of that. But interesting to see the median age of our admissions. We're seeing much younger patients admitted to the hospital with COVID, including patients in their 20s and 30s who are admitted to the ICU. Very sick. Our average length of stay once you get into the ICU is usually 10 to 14 days. So it's no short stay typically for these patients. And that creates all kinds of resource challenges and inefficiencies within our hospital that we have to address and deal with. If you go to the next slide. This shows what our ICU census looks like by month over the last 2 years. We built this new hospital. We have 48 ICU beds. We've never run an average census above 30 since we opened. So our staffing models, even though we have the physical space, have built around taking care of, on average, it'll go above 30 at times, it'll go below. But for an average month, you can see what those numbers look like each month prior to COVID. As COVID picked up, you can see we surged to 44, 45 ICU patients, which again, that's an average. So at times we are in the 50s, we are higher than that, overflowing to other areas. And we just have not had a model set up to take care of that kind of influx of critically ill patients. If you see what's starting to happen now at the end here with the last couple of months, July and now into August, that ICU census is climbing again. It's certainly above the 30 patient threshold that we've traditionally been at. And what's compounding that is our hospital is full with other patients. So we have many more strokes, heart attacks, traumatic injuries from recreational activities and accidents that are making our hospital much fuller than it would be in the summer. Summer is usually a slow month in a hospital, right? All the infectious disease kind of dies down, and other than traumatic injuries and things, we typically see lower census in the summer months in hospitals. Exact opposite is happening this summer. So as COVID is starting to pick back up in terms of impact to our hospital census, our hospital's already been pretty full with other patients. If you go to the next slide, it just shows you similar data for our acute care patients, which includes ICU. And you can see, again, historically, hovered around 160, 165. And since COVID, we were up above 180 patients, and we're starting to get back above 180 again. So all of that is just to sort of convey one of the messages that I want to share, which is as our COVID numbers increase, it has a direct effect on our ability to care for everybody else in this community. We have finite resources, and as we see stroke patients, as we see other critically ill needs, our resources are being stretched considerably to do that. If you go to the next slide, our high of COVID patients during the kind of the peak of the pandemic was right around 80 COVID patients in our hospital. Today we're at right around 40. So you can start to see where that's climbing up again. Some of those lines that you're seeing on this graph are intermountain projections based on different algorithms that we run with vaccine uptake and other things that we try to project. Where do we think that curve will go? The latest information I've received, and Dr. Ford may speak to this, is August is going to continue to increase in terms of hospitalizations and likely into early fall, peaking somewhere potentially in early fall. And we're hoping starts to come back down after that. So if you go to the next slide.
Can I ask you a question?
Yes.
About that slide?
You bet.
Did you incorporate data of when the UVU and BYU students return to this area?
This is sort of an Intermountain statewide algorithm, so it probably doesn't factor in regional, things like university towns and students coming back. Certainly, I would expect that has an impact on our transmission rate, and just depending on what the vaccination levels look like for the students, that would certainly have an effect, I would expect.
Okay, thank you.
Good question. So not to be too redundant, but like many businesses, we're struggling to hire across the board in all all of our job categories, even finding housekeepers. It's interesting. We are, short about 25 or 30 housekeeper positions right now. So our ability to just clean the hospital with all these patients is a challenge, but we're seeing it across the board in all of our classifications of job codes. I mentioned, the strain with the non-COVID patient numbers already being up. When we get above 90% efficient, full at a hospital, we really start to impact our efficiency. The turnover of rooms, the ability to move patients from the emergency room setting up or from surgery into the hospital, it gets extremely difficult to move things once you get above 90% capacity. And so when we have to run above 90% for an extended period of time, it has an impact. And then I think I already mentioned this last bullet with when we expect the estimated peak based on our numbers. My last slide here, we're doing a number of things. We are bringing in a lot of out-of-state travelers to help us with staffing. Many hospitals across the country are also doing this again now. So the ability to pull in those resources is limited to help us, but you can't train an ICU nurse to be ready to take care of ICU patients overnight. So bringing in travelers is some of the kind of the quickest countermeasures we have to not just continue to ask our existing staff to take on more shifts and to work harder, which we've also done, but we are bringing in a number of travelers to help us. There's internal adjustments we can do inside the hospital that help free up the ICU resource, which is limited in terms of how we take care of certain patients in different areas of our hospital by different teams. So those are things that we're working on. During the pandemic peak earlier this year, we had a system-wide Intermountain approach to redeploying certain staff, both doctors and what we call advanced practice providers or nurse practitioners or PAs, to kind of help us out on our units where we're really full. And we're starting to look at how we try to do that again. One of the benefits we had when we did that was a lot of those clinics were shut down for a number of months. So we had doctors and nurse practitioners that were looking for work, looking for things to do. It was easier to redeploy them That's not the case today. Those clinics are all up and running, so it's a little bit more difficult of an adjustment. We are making adjustments to how we kind of plan our surgery schedule. We haven't limited who can get surgery. Although if things get much tighter, we will have to start looking at how we limit that. That has a direct impact on capacity and just our ability to care for people. People that require an inpatient stay after a surgery usually have something more critical going on, so you can't delay all of those, obviously. But, our sister hospital in St. George had to do this recently because they simply couldn't accommodate all of the surgical demand they had, plus take care of the rising number of COVID patients that they were seeing. So those are some of the things that we're trying to do to counter out this peak that's happening. But I think my message, and certainly want Dr. Ford to have some time to speak to the vaccine, is the choices being made about the vaccine, they will have a direct impact on people's ability to get normal care in our healthcare settings. There's just no question about it. And most people don't think about the hospital because they're not planning on going there, and I get that. We're there every day. But our ability to take care of this community is being significantly hampered by the number of COVID patients going up each day. So happy to answer any questions.
Yeah, thank you so much. Good info. Very eye-opening. As we have to make choices about how we're going to allocate resources towards maybe some sort of information campaign or something like that, are there specific age groups, demographics, high risk? Who is it? I know you can't just generalize, but who is it that's ending up in the hospital? Is it older? I don't know. I just look at some of the numbers, like only 34% of kids 12 to 18 have been vaccinated, but maybe that's not where we spend our most resources, even though there's the most upside there, right?
Yeah.
So any guidance you can provide there?
Yeah, and I will defer to probably Dr. Ford on that. I think my opinion is we are seeing younger age groups hospitalized, 20s, 30s, 40s. I think we've had higher adoption rates above 50 and 60 in terms of the vaccine. I think that's true for our county as well. Demographic wise, I think, some of our adoption rates amongst the Hispanic community are not as good as they should be. From the beginning, we've seen higher percentages of the Latinx population being an admitted hospitalized patient. And Larry can maybe speak to some of that in terms of what he's seen. So I think there's certainly opportunities within that, that demographic in that community. And it's the younger demographic as well. So.
Okay, thanks.
Yep. Okay. I'll let Dr. Ford maybe take it.
Hello. Am I good? All right. You and the camera people. I'm Larry Ford, infectious disease physician here. The only one really between Salt Lake and St. George, but I'm here, so you guys get me. And I'm selfishly here. Without offense, I don't want to be here, and I don't have time to be here. But this is important because I live in the city. My kids go to school in the city. It's a good city. We're here by choice, and we're struggling, both as a society. That's a separate issue. Good luck fixing that. But from a healthcare perspective, we are struggling. This presentation isn't as polished and pretty. It's bare bones, and then answer questions. And is this a viable mic for me, or do I? Not mic. Thank you for. Does that have a pointer? Oh, clicker. I thought it was a pointer. All right. So I wanted to bring in a graph, but you guys can Google graphs. To date, this virus is horrible. In this country alone, more than 35 million cases, 613,000 deaths here in Utah, 435,000 cases, 19,000 hospitalizations, 2,466 deaths. Our death last night was a 27-year-old, a pregnant girl who's doing poorly. Anyway, and of the admissions just overnight, I'm older than half of them, and I don't think I'm that old. I know I'm not 27, but the point is it's skewing the virus, and the reason is the Delta variant here. I think it was from the CDC, but this is a different virus. It's not an entirely different virus, but this virus, in terms of its, more than 90% of the COVID in the state now is now the Delta virus. So they're still checking, but it's, the state is doing a good job about that. More than 90% of them are this Delta variant. It's a worse virus. The biggest issue is its transmissibility. The viral load, we talk about how much virus is in, on, and around you. And, it's up to 1,000 times greater in infected people than the wild type virus, meaning the original, virus that came over from China these many months ago. So it's an increased viral load, which means you're contagious sooner and you're much, much, much more transmissible when you have an infection. Because there's more virus, it's correlating with a greater illness severity and mortality. How much increase the mortality is still, the science is ongoing, but we're seeing younger, sicker people. Before in the olden days, before vaccines, social distancing, hand hygiene, masks, those things were sufficient. But at this point, just space and hand hygiene alone isn't enough. And I already said it's affecting younger and healthier individuals versus versus the wild type here. Thankfully, we have vaccinations. There's 3 available here. There's 2 mRNA ones. I know you guys can, I'll try to go quick here, but there's 3 vaccines, 2 mRNA, math, 3 vaccines, 2 mRNA. The Pfizer and Moderna, those are the 2-dose ones. The Johnson & Johnson's the single dose. It's a different vaccine platform. It's a viral vector. Talk to me after. I'll tell you all about it all day long. That's all I think about these days. These vaccines are fantastic. The science moved quickly, which was fantastic. All of the testing and all of the approval, all of the science was done the same standard. They rushed all of the approvals and all of the bureaucratic, instead of we're going to submit our data and then in 3 months we'll review it and then in 2 months so the science wasn't shortcut. All the administrative part was, thankfully. And in terms of just safety and efficacy, it's well established. It's safe. It's effective. Right now, the Delta's tweaking these numbers a little bit, but in all cases in this country, it's about 90% effective at preventing severe illness, hospitalization, death, the things that get you really sick and really dead. It's the Delta variant. It's seeming to hit people, and you're getting more either asymptomatic, meaning no symptoms, or mildly symptomatic infections in vaccinated people. It happens sometimes. I think recently, again, it's changing so much even over the last week. But as a system with Intermountain, it was 94% of the hospital admissions were for COVID were in unvaccinated patients. This is now a pandemic of the unvaccinated. If it stuck with them, that's not what I mean to say, but if it only affected those people, that is truly their decision without a bearing on anybody else. But with the transmissibility, it's a low likelihood that a vaccinated person will get sick, and a much lower likelihood they'll get really sick. But if you get a lot of cases, then a small percentage of a big number is adding up. But again, it's still a pandemic of the unvaccinated in the hospital. That's who they all are, almost without exception. In terms of the vaccine safety, again, I'm not breaking any news to you here. There are mild side effects. You feel crappy, you get a headache, maybe some low grade fever. I was that. It was back when I was able to work from home anyway, and so it was mild. Serious side effects are very rare. It's not the kind of it's like any other vaccine, basically. We've had more than 12 months of safety data since they started enrolling in the trials that got the drugs approved, and then it's been more than 7 months. Mine, as a healthcare provider, my course started in December, so we're 7-8 months now of widespread vaccination, and we have that data. Just a little side note there. And I'll read it just so with vaccines, every vaccine for the last 200 years, every vaccine, we've had no serious, permanent, fatal, any major side effect after 2 months post-vaccination. That's just how vaccines work. We don't have 10-year safety data on this vaccine. Yeah, that's fine. They'll keep watching it, but it won't change. That's not how vaccines work. I think the next slide. So there are a few very rare but serious side effects to the vaccines. The J&J, Johnson & Johnson, there's this, basically it's a clotting, bleeding, simultaneous syndrome. They call it TTS because it's easier than saying thrombosis with thrombocytopenia syndrome. I've practiced. And then a Guillain-Barré, which is an ascending paralysis. Both really rare. You know, the Guillain-Barré is 1 in 500,000 with the vaccines, at least so far we're seeing. And the thrombosis was thrombocytopenia, under 100 cases out of millions that have been given. And then myocarditis with the mRNA ones, especially in younger people. Now you could stop there and say, you know, holy crap, that is, can I say crap? And I said it twice now. So let the record show. These are serious, but compared to jumping down to number 5 there, compared to a natural infection, meaning compared to actually have an infection, those are the things that happen with infections, with an actual COVID infection, but at way higher rates. I mean, clots are 1 in 10, you know, maybe 1 in 15, as opposed to 1 in 500,000. And so it would be another thing to consider the risk, because, you know, there's always a relative risk. It's a very, very low risk. It's one thing if that was the risk profile for an Ebola vaccine, because there's no Ebola around here. And so then the risks may make you tip your equation. In this case, go outside and it's a raging pandemic in the city. So the very, very low risk of potential side effects are much, much lower than what we're seeing at much higher rates for a quote unquote natural infection, for a real COVID infection. And so that should tip. And I think I said, yeah. So side effects are seen within days or weeks up to 2 months out. I mean, that's how immunity works. That's how our immune system works. For a vaccine, especially because it's a prescribed small amount, it's a one-time dose, as opposed to a natural infection. The word natural makes it sound welcome, but in contrary, it is in your bloodstream, it's in your organs, it's shutting your kidneys down, your lungs, it's everywhere. And in an unrestrained, uncontrolled fashion for days and days until your body gets it under control. We have medications that help some, but very little. So in this case, the long-term side effects for an actual natural infection are fairly common. Some studies will say up to 10% of people with infections will have long-term symptoms, whether it's officially a long COVID or these long haul syndromes of, shortness of breath, fatigue, heart inflammation. They're setting up clinics now, Intermountain is, and probably elsewhere, of following some of these patients and trying to see what can help. And it's really just, the virus is long gone at that point. It just stimulates this completely overactive immune system, which, because it was a diffuse infection as opposed to a singular prescribed narrowed dose of vaccine. Vaccination. Vaccinations always have a better side effect profile than the actual infection, because this is oversimplification, but what you're doing is you are simulating an infection. Just briefly giving it these spike proteins, your body responds as if it's an infection, and then it creates immunity that will then protect you if you're exposed to an actual infection, as opposed to this ongoing actual infection, which has a much bigger effect on the body. By no means am I saying 90% of people who get this are sick and dying. No, and most people, it's a short, self-limited illness, but at much higher rates than influenza, the flu, and some of these other viruses, it's much more transmissible and it's causing severe illness. And part of it is just our ability in the hospital to take care of people. Kyle not alluded to it. He said explicitly, we're strained, we're burnt out, we're overworked. The ICU is full. There's not space. If it only had an effect on the individuals that did it, I would sleep just fine at night. But the effect on the staff and the nurses, it's not okay. So rampant misinformation. I heard described yesterday as non-evidentiary sources of infection. because we hear the word misinformation 800 times a day now, if you turn on the news. And so there's question about fertility that there's nothing. Every once in a while you can get some of the misinformation and you can extrapolate, all right, this is what they read and they see, and they threw in some misinformation and some legitimate confusion, and then it spun out of control. In this case, there's nothing. I just pulling stuff out of places. So there's question about whether previous infections preclude your need for a vaccine. Vaccination produces a stronger and more robust immune response, and it's longer lasting, which we can compare, and we have been comparing over the last year, to people infected versus vaccinated. And people who have had an infection and are then subsequently vaccinated still get a stronger and longer lasting response. With COVID, with a quote unquote natural infection, as bad as it can be, your immune system often produces a response, but doesn't always. You can't count on the fact it did. And also with the new variant, if you had a wild type virus, some of the earlier ones, the kind of cross-reactive immunity isn't as good as you would want. All the more reason to be vaccinated, even if you weren't infected. There's the whole young and healthy concept of, I'm young and healthy, and, you're right. There's a good chance you will get it. You will get sick and you will be okay, and you will stay out of the hospital, and I will never meet you. And that is a good thing. Unless you're not. And the bigger issue is, as we saw last year, is fall and college brought in and spun transmission out of control, is the risk of transmission to the vulnerable. I mean, we think of college students as living in an isolated dorm in a bubble, and that's not the case. If you were a pre-med student, you didn't leave the dorm much, hypothetically. But and also some people are using data now, using data from March of last year to compare to now, and it's a rapidly evolving and worsening virus. It's not. It's a very, very similar virus, but like I said, it's a dissimilar virus. So in summary, vaccines are the answer. I wish I was a great orator and I could convince you and compellingly tell stories about how horrible it is and how much people need to vaccinate. I'm not that person. I'm the one that takes care of those people. And I don't know what the city council does. I know you do good things. I don't know what exactly you do. Most of what I know about city is from the show Parks and Rec, and I don't know how accurate that is.
It's really accurate.
I hope it is. If so, I might stay for later meetings. But in all seriousness, I know you're not, going to stand on the corner with the sign that says vaccinate. I want you to, but it has effect on the city. It has effect on businesses and openings, and it has effect on education and schools. Again, I have kids in schools, on recreation, and I have not gone the racquetball courts at that rec center, that rec center are so nice, and I have not been able to go to them in so long. The point is, this cycle of horrible is going to end. Thank you. Please questions, because I assume I'm not here for.
Mr. Fillmore.
Chairman, thank you. Dr. Ford, thank you for that presentation. I would characterize that as lively and informative. Thank you. First question. What can you tell us about the duration of immunity from the vaccines?
At this point, we're over a year out from enrolling in the initial trials, and there's no real talk of boosters. The companies that will sell you the boosters are getting ready and getting the data ready, and we're looking at all of those things right now. Over a year, we can say, with no talk of, at least no short-term planning for boosters. They may be needed, especially if variants occur when there's uncontrolled replication, when there's just spreading it's around. And so, vaccines are what are going to help us with that. I'll actually answer your question though, is there may be boosters needed, but right now, no need for such, and at least this year, I wouldn't anticipate the need for such.
One of the reasons I ask is because early reports at the beginning of the pandemic last year, summer and fall, were indicating, perhaps anecdotally, that antibodies were petering out after a few months.
They do drop, but we have more robust data. I know in Israel, they're starting to revaccinate some of their immunosuppressed. But there's lots of other countries' data, in aggregate we look at, and still not a need for boosters at this point.
Okay. Next question. There obviously are a variety of variants out there. Brazil and Delta variant and a lot of others. How confident are we at this point that these three vaccines, Pfizer and the others, are broad enough in their protective impact to guard against these variants?
It's a good question. And what is actively being tested, I say this with I'm not personally running these studies, but here locally and nationwide and internationally, they're following that all very closely. And so far, they're still covering them well. I mean, it used to be the protection against severe illness and death was with the wild type virus for some of these vaccines was 94, 95, 96%. In aggregate now, it's creeping down to 90-ish%, which is still very good. If we had a seasonal flu vaccine that was that effective, that'd be fantastic. The flu just changes too quickly.
Yeah.
So they're watching for it.
So it's not quite as impactful, but pretty close.
Still very good. Yeah.
Okay.
A 90% effective vaccine, at least against severe illness and death, is still a godsend.
Last question for me. It has to do with the so-called long haulers. What is the prevalence of long haul effects from people who had COVID?
Prevalence meaning how often is it happening?
Yeah, I mean, we read about brain, heart, and lung damage.
So some studies will show up to 10% of people that get it. It's more common in people that are severely ill, but people who are asymptomatic or minimally symptomatic also have some of these long symptoms. Most of the time, it's not severe and debilitating. It's, a month later, you're still short of breath up a flight of stairs. You're still having chest pain. I talked to a lady a few weeks ago and, instead of, she was so happy because she went a whole day without taking an hour or two nap. And that sounds, first of all, glorious, an hour or two nap, but for her, it was to function. It wasn't, it wasn't leisure. And it usually gets better over time. There are some people that it seems to trigger more persistent, immune dysregulation and this fatigue and shortness of breath. So 10% does seem a little, up to 10%,
Okay.
probably a little less.
But you're saying those, for the most part, are transient.
Generally,
After
yeah,
effects.
yeah. Some of them are still just as inflicted, but anytime you have any infection, it can trigger. It triggers your immune response, and sometimes it can cause problems and fatigues. And
I take it there's really no way to predict who may be a long haul victim.
not yet. Ask me in 5 years, and I might be able to answer that.
That's the catch, right? Is we're making the best educated guesses we can.
Yeah,
Thank you.
sure.
Mr. Hardy?
I was encouraged to see the IHC, the Intermountain prediction of the cases and peaking in September and coming back down. In my very uneducated, look at the graphs, just looking at year over year, we're higher than we were in the start of August last year, and we have been for the past 3 months. And so that to me that's where I was losing sleep over was, what does this look like in December and January of the coming year? So I'm very encouraged to see this prediction going down. Obviously, like you say, the Delta variant is almost a different virus, different conditions, different characteristics.
And without interrupting, but I just interrupted, without rudely interrupting, the only thing about a month ago, we were where we were in August or like October, November, right when we were going up, and then we just went up and up and up and up. The vaccines, as insufficiently numbered as they are locally, they're at least enough that it's preventing that explosion. And among the highest risk, the cute little 80-year-old grandmas, they have a higher uptake than so we're spared from where we have been spared for that because we would have already exploded, but we're already now stretching capacity again. And
okay, yeah. So this year we have the vaccines that at whatever rate that they've been adopted, but last year we had, I think, some more kind of social distancing type. That the society was practicing it a little bit more than we are now. So So it'll be interesting to see how it play out, but I just want, I appreciate your thoughts on that, because I was very happy to see that prediction of it coming down before the end of fall. Thank you.
Thank you very much for coming to talk to us about this, and just really appreciate all that you're doing for our citizens at this very difficult time.
Then if there's questions, you collectively got a hold of me. Let me know if there's questions. I'm happy to help. Okay.
Thank you very much. We
Thank you.
appreciate that. So counselors, this discussion and presentation was originally prompted by the question from one or more counselors of whether there's something that we can do in our roles as city leaders, perhaps some type of education or outreach campaign. Considering the time, we don't really have a lot of time to dive into that, but are there any initial thoughts? And I think we'll probably have to have a follow-up discussion on this.
Do we have extra time because one of the agenda items fell off?
We do. We could maybe take up to 15 minutes. So
Gotcha. I don't know what the solution is, but I'm generally supportive of anything that we could or would do. If it's a honk and wave, let's do it. I think this is absolutely extremely critical in our community. Sorry.
George Hanley has his hand raised. I don't know if you guys can see it, but we can see it on our screen.
Thank you.
I'll continue.
Yeah.
I was just going to say, there are really broad repercussions that I think will ripple through our community that we can't totally anticipate. And I'm thinking of a lot of unvaccinated students coming back to our community, them getting the coronavirus or the Delta variant, and then some of them being hospitalized. And a lot of those students don't have health insurance. And if they are hospitalized for 7 to 14 days, the financial burden for them, for their families is tremendous. So this is not, for young people especially, if you don't have health insurance, if you are one of these, 60 or 70,000 students that lives in Provo and Orem, this is tremendously serious. And I don't know what the solution is, but I'm supportive of a solution.
Thank you. Counselor Henley, I apologize that I didn't see your hand up on the screen. Please go ahead.
Yeah, thanks. Can you hear me okay?
Yes, we can.
I just wanted to remind the council of the email that we received from Casey Gifford that offered, she's an MPA student who offered some very helpful suggestions about things that we could do. And education actually is not one of the recommendations. It doesn't seem to be as effective as other methods, but I wonder if, in light of her recommendations, we could consider coordinating with the administration on this and determine, first of all, if there's funds that we could use from the government sources that have been given so generously to our community for this kind of thing. I would hope we could make some inroads on those recommendations, because I think they will get us some traction. I'm very concerned about the report that we just heard regarding the Latinx community in Provo being behind schedule on vaccinations. I think that's concerning to me. The arrival of college students is concerning. It does seem to me that age 30 to 50 demographic nationally, and I think I caught that in the report we just got, is the demographic that's ending up in the hospital quite frequently and not vaccinated. So I think we've got to figure out some targeted strategies that are positive and upbeat, and maybe offer some incentives to make that happen. The ease of the process is really important. in her study. So I think we could look at figuring out some ways to coordinate. She also mentions, working with the medical people in our community directly to sort of figure out ways to get providers to make more direct encouragement to their patients, because that seems to be very effective. So anyway, I think we need to do something, and I think we need to do it as soon as possible. And I would hope that we could coordinate that with the administration.
Thank you. Mr. Fillmore?
Thank you, Mr. Chairman. I think the absence of a recommendation on education doesn't necessarily mean education is an important thing. For her particular report, she had some recommendations there, but I have to think education, and particularly coordinating that with the mayor's office, is a very valuable component. And perhaps, as Mr. Hanley suggests, there may be ways to incentivize that. I think we've got to also keep in mind the need to be helpful and supportive of the major institutions here in town and the initiatives that they take. I'm talking about universities, IHC, hospitals, and the school district. We don't control them, but we need to be helpful and supportive. We all have battle scars from last year's pandemic efforts as we tried to get ahead of the curve and went back and forth on mandates and what can the city do and our own city ordinance. And I think one thing we probably ought to learn from that is that whatever we might think to do is going to be almost inevitably preempted by the state and county. When all was said and done, we ended up deferring to the state guidance and what the county did, and our ordinance was superseded by that. So I'm not personally not in a hurry to come up with a new ordinance by way of mandatory behavior in the city.
Mr. Holden?
So I agree with Mr. Hanley about a targeted approach, and that is disheartening to hear about the Latinx community. So I think, and that's the reason I was asking that question earlier, is I think it'd be nice if we could try to really dig down into some of these data points and really determine, okay, what's going to give us the most bang for our buck, because we will have limited resources, of course. And also, like, for example, students. So if you look at the 19 to 29 age group, they have a very similar vaccination rate as the 30 to 39 age group. But the 30 to 39 age group is twice as likely to end up in the hospital. So if we had to, pick or choose there, probably want to spend our resources on the 30 to 39 age group. So that's just one example, and I'm no expert, and these are national stats from the CDC. So it might be different in Utah, of course, but I guess I'm just putting in a plug for whatever we do. I'd like it to be targeted as opposed to just broad sweeping. I think a broad sweeping approach is whatever we do is not going to be nearly as effective as if we really kind of target our audience on it.
Mr. Harding?
I too think this is a very serious concern that the Provo city government would do well to respond to with the time that we have. And I know not every counselor has spoken on this, but I think hopefully the administration gets a sense of how important we feel that this is. And I think perhaps a way to move forward would be to request that the administration maybe work with our Intermountain partners and the people from BYU and formulate a proposal to bring back to the council on how we can move forward together on addressing this. And I did want to mention here under the outlining of in the PDF that was sent to us. There's a paragraph here. It says, "You may be surprised, as I was, that a public education campaign did not make the list. Unfortunately, these campaigns do little to directly increase vaccination uptake. though they may have an indirect benefit. So, but in some of the others, it seems like if we're trying to connect individuals with doctors or medical professionals, perhaps, that there's an education component to that. So anyway, I just think with the time that we have and with the urgency of this, perhaps the best path forward would be to ask the administration to coordinate a proposal.
That kind of sounded like a motion.
Sure, I'll make that motion. But I'm happy to, if other counselors want to refine it, I'm happy to hear what others have to say about it.
Mr.
I
Chairman,
would second that.
it might be helpful at this point to ask Mr. Parker, who's surely following all this, what initiatives the administration is currently contemplating.
Sounds good. So we have a motion and a second, and we'll have a little bit more time for discussion after we hear from Mr. Parker.
Thank you, Mr. Chair, members of the council. Just so you're aware, this is an issue that is a daily topic of discussion with the administration. We have multiple times a week, we're in contact with the county health department, looking at specific Provo data, trying to determine what we think are the right approaches. You should know again, one of the challenges of our newsletter cycle is that we are 7 weeks out from sending it, getting the copy done until the last house in Provo receives it. Just the nature of sending out 33,000 mails with utility bills. But the September newsletter will have data and information about the efficacy of vaccines and dispelling some myths around vaccines that we know about. Again, we're gathering data from our public health professionals at the county and state level. We are reposting a lot of things that are being posted by the state and the county health departments and trying to get them out through our social media channels as well. So the education effort, we haven't been silent on it by any means. More aggressive education, I think the data that we've seen has suggested that the traditional education efforts of saying, did you know this about the vaccine or this about the coronavirus, is not particularly helpful. What tends to be more helpful are influencers in areas where we find low uptake of vaccine opportunities. And so you suggested the Latino population, students, those who just have simple distrust or mistrust of government, who don't believe our messages, are more likely to receive those from community influencers as opposed from a direct government message. And so it's a multifaceted, approach that defies our traditional ways of trying to educate and inform the public. So again, I think in many ways it's providing resources in our community so influencers can utilize their influence of doing what they do best. And whether they're social media influencers or elected officials or neighborhood chairs or ecclesiastical leaders or whoever those might be, that could wield greater influence than a traditional government education program. That's probably among the most effective ways of trying to get the word out and change behavior. So again, we're looking at all those. We're happy to respond to your motion, assuming it passes, and bring you back some thoughts about ways we might further enhance the effort. But I just want you to know that we've not been sitting on our hands doing nothing about trying to encourage the adoption of the vaccine.
Thank you, Mr. Parker. And just a quick thought or two before, actually, Mr. Shipley, do you want to go ahead with your? Well, for you first. Okay. I thought it was interesting in that BYU research, and I'm hoping the administration is.
I have not seen it, so.
Council staff could make sure that all of the mayor's office has a copy of that. That would be great. One of the things that I found very interesting is that the suggestion that they recommended the most, that seemed to have the most effect, was when a person's healthcare provider, their family physician, somebody they trust, encouraged and recommended it. And they even had a study that recommended some specific language So next time you're due for your annual checkup, if the person who's calling from the doctor's office says something to the effect that if you'd like the vaccine, we have a dose ready and waiting for you when you come in, just little things like that. They were actually able to measure the difference that made, because there are people who are definitely opposed to getting the vaccine, but there's still a fair number that are just kind of just busy and, not sure about it. And just a little nudge could really make a difference. So any other discussion before we vote on the motion? Mr. Shipley.
So along those lines, the MPA report, at least what I interpreted from it, had three, to summarize, a few suggestions at the end. One was to have the care providers solicit, their own clients and their own patients to come in and get from them. One was to make it easier, I think, to have accessibility, just make it as easy as possible. And also one was incentives. And I'd just be curious from Dr. Ford or from Mr. Hanson, if do you guys have suggestions or feedback on those three specifically? Because I think if we're going to look at specific things like Mr. Hoban was alluding to and try to be a little bit more calculating how we do this instead of just a broad base education, I think we'd appreciate some feedback on those three things specifically.
There's not I wish there was an answer.
Not a one size.
It's all community.
For our Spanish speaking community, do you hear from patients that they just didn't know, that they didn't have it available? I mean, specifically for them, are we missing something in our efforts to educate in Spanish speaking, for example, or in the Spanish language? Or, I mean, what do you sense is the next thing we need to do potentially to just reach more of that community? Thank you. Sorry.
I'm walking up here to
Appreciate
say
it.
I don't know. I'm less the policy side than more on the patient care side. There's sticks and there's carrots, and there's going to be mandates and there's going to be employers mandating things that are they're going to tilt, and they're starting to tilt. There's going to be carrots for people that are bad at math. There's lotteries. I think that's kind of silly. It's kind of friends. It's influencers. I mean, I'm not saying we should hire local influencers. They don't need any more attention, but it's just outreach. And I know that sounds vague and it sounds broad, but it's going to be your peer group talking about it in a not crazy way, and then going to talk to a healthcare provider or reaching out to somebody who knows. In other words, I don't know. It's community dependent, but I trust your expertise.
Okay.
Plaques and everything by your name. That's a good sign.
I mean, anything. Thank you.
Can I ask a quick question?
Yes.
If in the Intermountain Network, if you do find some successful strategy, would you please reach out to us directly to share that?
Yes.
Thank you.
And we'll task Kyle with that as well.
Excellent.
Thank you.
All right. In the interest of time, unless there's urgent questions or further comments, we should probably vote on the motion. The administration is probably better equipped to come up with a plan than seven of us trying to work it out on the dais. So,
Will you repeat the motion?
I think the motion was something along the lines of requesting that the administration work with our Intermountain partners and I've already forgotten, and Casey Gifford to develop a proposal on how we can, a program or some efforts that we can do to try to increase the uptake of vaccines in the community.
Would you be willing to amend that with a timeline or a date?
Sure, absolutely. Would you like to propose a amended date?
In 2 weeks, is that suitable?
Is that something that the administration feels that is reasonable?
next meeting is in 3 weeks, by the way.
3 weeks then? Mr. Parker?
Okay, I would happy to amend my motion.
to hear from them with a plan in 3 weeks.
Yes.
And does your second stand, Mr. Hanley?
Yes.
Okay.
Just have one question. Seemed to be like the list of people to coordinate with or collaborate with was a bit limited. There are quite a few stakeholders. We have 2 universities, we have public school system, in addition to IHC, the county health department. I would amend the motion to include all those stakeholders.
Yeah, I'd be happy to make that more generic, and just refer to community health partners and
Sorry, could the motion just simply allow those that we've identified to consider those possibilities rather than to dictate it at this point? Because we don't know who those willing partners might be yet.
Agreed. I would like to make that more general and yes, invite the administration to work with our community health partners. If is that general enough and covers the ones that we've considered? Yeah, okay. So I would like to amend my motion as such.
Mr. Hanley?
And I would still second that.
Okay. Are we ready to vote? All in favor? Mr. Hanley?
Yes.
Okay, and that motion passes unanimously. Thanks again for coming to educate us about this. Let's move on to item number 3, which is a presentation discussing a proposed ordinance for transferring private ownership of streets and utilities to public ownership. And this is to be presented by David Day.
Thank you. Just want to make this as brief as possible and we can expound where we need to. I noticed on the agenda that you have a break after me, so I don't want to delay that. This is more of an overview than anything, just kind of getting you up to date. Some of the council have been involved in this issue and some haven't. So maybe just wanted to give you an update of where we're at. We're in the process of creating an ordinance to allow transfer of privately owned streets and utilities to publicly owned by Provo City. And the background of that is that we have a group that would like to transfer their private roads and utilities to Provo City to own and maintain. And when we got looking into that, we realized that we don't have an ordinance that describes how to do that or how that works. And the reason for that is it's never happened in Provo. So we're charting new territory. We're in the process of creating a new ordinance that has never existed in Provo. We've created a draft of that ordinance. And I think you've all got like a copy of that. It's a work in progress. I'm sure it'll change from where it is right now, but that's the starting point. I think it's a good starting point. And if you have any questions on that, we can take those in a second. Maybe just a little bit of the process of where we're at right now as the council work session. We'll take your input, and if you decide that you want to proceed with this, then what we'd do is take that proposed ordinance text amendment and create it as an official submittal to Development Services to change the ordinance. That would take maybe a couple days to do that. And then we would have staff would comment on that ordinance text amendment, and then it would move on to Planning Commission quite quickly. Planning Commission would then look at it, take public comment, make their recommendation to you, and then you would get it back again in whatever form it comes to you in, and you would look at it, make any changes that you felt necessary, and also take public comment at that time. So that's a real quick overview. I'm sure some of you know a lot more about it than maybe you want to, but I can take any questions or discussion now.
Mr. Hardy?
I know you described it as a work in progress, but I think it was a very good draft as in the form that it's at. I think you're well on your way, and I'm supportive of this effort. I find it interesting that the current Provo policy is private streets created as part of a platted subdivision will not be considered for public ownership unless there's a compelling public interest. So that's the current policy. So we are looking at a change to that. I appreciate section 2, I guess it would be referred to, that talks about how to determine if it's in the public interest, or I guess here it talks about a compelling public interest. I think one thing that you might consider in organizing it is, already if there is a compelling public interest, then the city can make a proactive effort. And I think that should still be the case. If there's something that's compelling, then we should proactively go out and try to make that conversion. On the rest of the spectrum, where here's compelling public interest, maybe neutral, and then something that's against the public interest all the way over here, and I could see this being something we proactively do. And then in here is something that we would respond to. If someone wants to come in and propose something, we would respond to it. But I would still hope that if something's against the public interest, it's not something that we would do. And so I think 2, that lists out the factors in determining whether there's a compelling public interest. I think those are the same factors where we could kind of see where it fits on the spectrum. And so rather than embedding it on the proactive, if we use those same parameters in determining where it's at, that way, if someone comes in with a proposal, then we could use those same parameters to judge whether or not it's something that is recommended or something that's not recommended.
I also might mention, we have a number of folks in this room that have had a lot of input into where we're at now. And so they can interject if they want. Matt with legal, and Brian and Dave Decker and Gary Calder have all had input, as well as Dave Sewell was helping us on this too. So
I have a question. Do you know how often does it occur that a private road does not meet the city's design standards?
Yeah, so
Is that most of them?
Right before I started with Provo City, there was a loophole. There definitely was. There was a different standard for private roads than there was for public roads. But right before I started here, they made that change to where all public and private roads were built to the same exact standard. I think that was right in the 80s sometime that change was made. They were experiencing issues with roads that had been built to less of a standard. Mainly it was the structure of the road wasn't holding up with the loads that were put on it. So right now, that's the way it is. It is that they have to be built to the same standards, so they are built equivalently well.
Mr. Jones?
Thank you, Mr. Chair. I did have one comment I wanted to make. I was not in the meetings. I think there was an initial meeting, then there was subsequent meetings where the draft was, and Matt Griffiths from our office is here and can talk about the process more if there are questions about that, or technicalities about the ordinance, but I know Matt did some research where he looked at other jurisdictions and what they were doing, and it varied anywhere from there being some cities that just say, we'll never do it, to cities with varying strictness in what they would consider. I think my understanding is that the draft you've got in front of you was based on Salt Lake City's ordinance. But there has been one change made to it that causes me a little bit of concern. If you look at the very last section, which is entitled Administrative Procedures, and I think that's because that's what the section in Salt Lake's code is entitled. And then, despite calling it an administrative procedure, it then grants the ultimate authority for the decision to the council, which strikes me as odd in our form of government, because I think that the council does not typically make administrative decisions. So, and it doesn't strike me that it is a legislative decision. So, you know, I don't know how much discussion was had on that point in the committee. Generally speaking, this seems to me to be the kind of thing where the council would designate the criteria, and then the actual decision would be in the administrative process. The only other I was trying to think of other examples where a citizen makes an application to the council to decide something, and the only ones I can really think of are rezones, which are because state code designates the city council as the land use authority, and parking permit programs, which we've done that way because creating a parking permit program actually requires legislation, actually requires an ordinance in city code. So there may be, again, I was out of town last week, so there may have been discussion on that point that I missed, that I'm a little bit out of the loop on, but that was the one part of the current draft that struck me as a little bit odd.
I don't recall discussion on that point, but do you have anything?
The only thing I could think of would be perhaps if a development didn't completely measure up to our standards, that they would be told no at that point, and maybe would appeal that decision. And if that decision had financial considerations, like the city had to go in and pay money to fix something, and then the council would have to appropriate that money. But that's really the only thing I could think of. I don't know if anybody else had any input on that.
Mr. Hardy?
Perhaps this discussion would be better offline, but at least the draft that's came with our packet seems different than what you described here. It only states that the mayor is authorized to adopt additional consistent administrative procedures necessary to implement this policy. So I don't know if that was what you were referring to or something else there.
Yeah, I was referring, the copy I have in front of me has 3 subparagraphs to section 030, and the first sentence says city council shall determine whether streets are dedicated. Okay, so maybe that's the issue, is that I have an out of date version. So,
okay, thank you.
Thank you. One comment that I had was, I think that health and safety implications are very important in considering this decision. And I can think of cases where I think it is a compelling public interest to consider such a conversion. A couple of examples that come to mind is fire hydrants. Those were recently discussed. I get a little nervous if the safety of citizens in an area is dependent on whether an HOA has the expertise, the motivation, or the funds to make sure those fire hydrants are properly maintained. Another example would be where there's private and public lines that are interconnected, either water or sewer. I had a family member that had a real nightmare with a sewage backup out in Orem recently, and I get nervous again if the lack of maintenance of either a water or a sewer infrastructure on the part of an HOA causes impacts not only to the members of the HOA but beyond. So those are some reasons I think that would argue for considering conversions in those cases.
I agree.
So as I understand it, then the next step would be to send this to the Planning Commission.
Yeah, so we were just hoping to get your feelings on this of, is this a good thing to do? And I think it is. And then, so we would take it from here and process it as a ordinance text amendment and put it through the normal system to bring it back to you. Planning Commission, then City Council.
Can I just follow up with one question?
Sure.
So I think Ms. Ellsworth was talking about our code now, whether or not it might incentivize or motivate a developer to do a private road just to get out of, meeting our standard. So the standards as far as utilities are concerned, as far as roads, it's all consistent. What motivates then a developer of a small project to then want privately, do we as a city give them any motivation to do that? Because I don't, that might be bad policy that we need to look at elsewhere if there's some kind of motivation that we're giving developers to do private lanes and roads and utilities that were then at some point may become a safety issue for us as a community to have to pay for conversion.
Yes, so the two that I can think of are gated, and to have a gate, you would have to have a private subdivision. So Stonegate and Vintage on the River are both newer type subdivisions that have gates. They were built to the same standard though as every other subdivision in the city. So
okay, so all the utilities, the roads, everything like that is still up to code though.
yeah,
Okay.
it is. But like Dave Sewell mentioned, some of the things that make us the most nervous is having a private water line where it's tied to the city system. I guess in a perfect world, everything would be the public system that we would own and maintain.
Yeah, thank you.
Mr. Harding.
Yeah, and I imagine a lot of this is just, history. It's things that came in, when the city policy was different, and now, people want to convert over. I guess my biggest concern is, and I don't know, I don't have the expertise. I don't know. I don't have the history to know if this has ever been the problem, but I could imagine perhaps a development that came in and wanted to do certain things, and the city said, well, that's really not, something we're comfortable with. It's that, that the grade on the street, the slope is too high or whatever. And then the developer says, well, it's okay. We'll make it private. We'll take care of it. You don't have to worry about it. And then decades later, they come back and say, well, hey, we want you to take over. And so that's my biggest concern is as we look at these, I want to make sure that we're not, people didn't get something through that they wouldn't otherwise because it wasn't in the public interest, and now they want to make it, the liability on the public. So that's my one concern on this.
Yeah, for the newer ones, that wouldn't be a problem. Part of our criteria for evaluating this type of an application would be to look in and determine whether they meet our standards, if it's built to the same quality, what condition their facilities are in, if they've been maintained, and try to get a good idea of what we would be taking over, so that we're not getting something that we immediately have to go in the next day and say, hey, we need to rebuild this whole thing, because we're not interested in doing that. We'd prefer them, if they wanted to transfer it to the city, to go in and do all of those improvements first, and then say, hey, now it's ready for you guys to take over.
And if those precautions, if those safeguards are in place, then this is definitely something I would support.
All right, any concerns about moving ahead with this? I'm certainly supportive. Looks like we have a go to move along with the
Thank you.
process. Thank you. All right, we are now scheduled to take a 10-minute break. So looks like it's almost 3:25. So let's make sure we're back here at 3:35.
The recording has stopped.
If we have something continue every single time, do that on there.
We would like to resume our meeting with item number 4, which is a presentation regarding city programs that are funded through CDBG and HOME funds. And this item is to be presented by Gary McGinn, Community and Neighborhood Services Director, Cindy Sweeten from the Housing Division Administrator, and Dan Gonzalez, CDBG Administrator.
Hello, I'm going to start today. I'm excited to be here and tell you about our programs that we run through our department, through our federal funding. Thought it'd be nice to give you a little bit of history about the programs and where we are today with those. So we have 2 pots of money that we run our programs with. We have our CDBG and our HOME funds. And I'm going to start with our CDBG program, which is Community Development Block Grant. I'm just going to give you a little bit of history about the program. It is a federally funded program that provides us with resources to run different housing and community or to fulfill housing and community development needs. Provo City has been an entitlement city and has been receiving this award, CDBG award, since 1989. The program can fund activities including the sewer and water, street sidewalks. You see the list there: community facilities, housing rehabs, planning, and public services. There is a catch though when using this money. These activities must principally benefit the low and mod income residents. Whoops, wrong way. So how are we spending our dollars that we get here in Provo? This year's entitlement for 2021, you can see, is just over $1 million that we've received. A large portion of this funding has gone to infrastructure projects such as sidewalk, curb and gutter, parks, and storm drain. It's also being used right now for airport improvements. And we put together several programs to assist individual homeowners within the city. We have an egress window program, an emergency home repair, a neighborhood revitalization, and a facade grant program to assist the business owners. We also rely on our partners in the community to help run some of these programs for the social service end of it, and you can see a list of them there. That's just a few of them that help us run the programs. I first want to tell you about our egress window program. This is a program I put together in 2016, and it helps Provo residents install larger windows in their home. There's a few reasons that we do this program. It gives them gives them a chance if they had a fire in their home that they could get out. It's for the health and safety of the homeowners. It is a loan/grant for low to mod income residents. They have to own the home. It has to be a single family residential home also. It is a 0% interest deferred loan with the possibility of forgiveness over a 5-year period. So if they stay in the home for 5 years, we will forgive the entire loan. To date, we have provided 29 families or homes with new windows, which equates to 76 windows between these 29 homes. And when we do this, we also open in smoke detectors, and that brings that bedroom up to code. And in doing this, you can see the amount we've spent over these past 5 years is just over $216,000. So you might want to know what neighborhoods we've been doing this in, and there's a graph up there showing you where those 29 homes fall within the neighborhoods. Couple pictures of our projects there. There's one cutting out the window and then the finished window there. Our current fund balance right now is just over $45,000, and with the new funding that we'll get this year for 2021, being allocated another $40,000, so there's just over $85,000 to spend on this program this next year. So our emergency home repair program, we're trying to figure out when this program started, a coworker and I, and she's been here 28 years, and she said it was here long before she started. So we're figuring over 30 years we've had some kind of program to help with emergency home repairs. This is for properties owned and occupied by low-income residents who are 60 years of age or older. Either they can be on Social Security, disability, or are active duty members of the armed forces. We've tweaked this program to hopefully better fulfill the needs of the citizens. So this year, up to $7,500 of that is a grant. That's usually what it costs to put a new roof on a house. And so we like to do as much of a grant as we can. If it's over $7,500 up to $15,000, then that $75,000 to $15,000 would be a loan to that citizen. It's a 0% deferred loan. They don't have to make any payments on it as long as they stay in the home. Once they no longer live in the property, they pay us back. There's a list of some of the possible repairs that we could do with this money. We have mainly done roof repairs due to water leaking in. We've done tree removal causing damage to a home, some plumbing and electrical to some of the homes. You can see there our current fund balance is just over the $63,000. We will be allocated an additional $45,000 with this year's funding, bringing it up to just over $108,000 to help residents with this program. We also have a neighborhood revitalization program. This is, it focuses on uplifting neighborhoods, and it is to be neighborhood driven. We want the neighbors to figure out what they would like and come to us with their ideas. Here again, the project must be in a CDBG eligible neighborhood, or the applicants must also income qualify, be under that 80% AMI. Projects, there's a list of projects we could do: pathways and lighting, ADA accessibility, safety crossings, paint your heart out, parks and equipment, neighborhood cleanup, landscaping, residential facade, curb gutter, sidewalk replacement. There are some pictures of some of the projects that we have done. We did the safety crossing over by the rec center. We did the toddler equipment at Joaquin Park. And then we also helped with the Mazer mural there that you see. And right now we have $21,000 in that fund that we could help a neighborhood with. One of my favorite programs is our commercial facade investment program, which I call CFIP. For over 35 years, we have administered some kind of facade program for business owners. Over time, of course, the boundaries have changed, the terms, and the guidelines to try and fit the needs for the citizens better. From 1986 to 2010, we did 35 facades. And then in 2011, it was decided with the major changes happening in Provo, we had the temple being done, the convention center coming in, New Skin was adding on to their building. Council decided at that point that they wanted to spruce up Center Street in the downtown area. So we came up with a new facade program that would help fit these needs. And so since 2011, we have done 37 facade improvements, and we've spent over $777,000 doing this. When doing this, we have national objectives we have to meet, and one of that is job creation. And so this has created a minimum of 66 new jobs that I can count. I'm sure there's been more that we don't have paperwork on. And then 17 of those projects were a slum and blight project. Now all the facades are job creation. And then right now it's the money is only for exterior improvements, and a business can have up to $50,000 depending on the amount of jobs that they create. Our current fund balance, you can see, is just over $77,000. With the new allocation from this year's funding, we'll have another 40 to add to that, giving us $117,000. Currently, I have 3 applications and 1 in the works. So most businesses use the full $50,000. So I don't have enough funding to fulfill all those businesses at this point, but we'll just see how things play out here. There's just some pictures of some of the projects we've done. I've got some amazing before and after pictures from all the projects, and it's just really fun to see how these businesses take on a whole new look. So that's our CDBG programs that we run. We have our home funds that we also run some programs with. HOME is the largest federal block grant that funds a wide range of housing activities, including building, buying, and or rehabbing affordable housing for rent or home ownership, or providing direct rental assistance. Here again, the activities have to benefit low to moderate income households. We administer 2 programs with these home dollars that are both down payment assistance programs. One is directly for Provo City, and the other one is for the Utah Valley Home Consortium, which is a down payment assistance program for the outlying cities within the county that are not Provo. Here, and then again, we also partner with our nonprofit groups to help deliver some projects with these dollars at Habitat for Humanity, rural housing, and the housing authorities. So the program that we run just for Provo is called our Home Purchase Plus program, or HPP. We've been administering some form of a down payment assistance program in Provo for over 22 years. Here again, the program is available for low to moderate income families anywhere in Provo City. What the program offers is down payment and closing cost assistance. There is 0% deferred interest loan. They can have up to $40,000. Usually they don't get that much. The average they've been getting is more around $17,000 right now. There's a formula that we have to put everything into based on their need and their credit score that says how much they can have for their down payment assistance. Right now, that current fund balance is $254,000 plus, and then we'll get another 200, so we have just over $454,000. As long as the people stay in the home, they do not pay us back. There's no interest. Once they move from the home, they do pay the full amount back.
And can I just ask, as a
Yes.
matter of practice, so does that show up as a lien when they go to sell the house?
It does. It places a second lien on the home, so it's a silent second.
So title would find that as a
Yes.
lien? Okay.
Yep.
Thanks.
We do our own closing, our own paperwork, and record it with the county.
Thank you.
So we also have one other kind of a hidden gem program. It's called Own in Provo. This is money that the city received back in 2004. It was HUD's EDI Special Project Grant. And initially, those funds were to be used solely for rehab loans. And in 2009, the council decided that they wanted to include a down payment assistance loan for people who were over the income. So if they were over the 80% of median income, they could use this money. So what happens is, so we get people applying for that down payment assistance, the HPP program. If they're even $1 over the HUD income limits, they don't apply for that program, but we can bump them into this program. The HUD no longer does provide money for this program, so this was just a one-time shot of money that we received. So it's a revolving loan fund that we use. The people pay the money back, we put it back in the program, and that's how we can keep some money going. Right now, we have just almost $292,000 there. So do you have any questions about these programs that I feel like we can do some great things for the citizens. We'd like to get the word out there more about the programs, and just let them know what we have. Do you have any questions for me?
So thank you. First of all, these are some fun programs, and I'm glad we have them. On this, the Own in Provo program, just can you give us a sense of like how many loans last year? Is it a program at that size that is becoming more difficult to really truly help somebody with a down payment, or is it still a really impactful thing to have a $10,000?
It is very helpful. We just closed one a couple weeks ago because the gal was just, $5,000 over the income limit, and so she was thrilled to get the 10. So yeah, it is very helpful to people still.
Perfect. Thank you.
Good.
Great, thank you.
Okay, you're welcome.
Good afternoon. I think the reason why I'm here is to bring back some information that was requested from last time that I was here about 3 weeks ago. And this is mostly relating to the CARES Act funding, CDBG CV funding that we have received. So just going to give you some information, then you can ask me some questions if you have them. We've received the allocation divided into stanches. One was just over $745,000, almost $746,000. That was back in May, I think it was, of last year. And then later on, we received an additional $487,000. So the total that we have received is $1,233,560. On both occasions, we've come and presented the proposed projects. But I think I'm going to focus mostly on the small business part of it, that with the first statute, we set aside $450,000. That was intended to provide small businesses up to $15,000 so they could do whatever they needed to stay in business or come back to business. With the second one, we had an additional $171,776. And then 3 weeks ago, the reason why I was here was to take back $65,000 from that total so that we could do some other projects. So the original, counting both of those, was $621,776, which if businesses had received up to $15,000, it would have assisted around 59 businesses. Obviously, that amount could vary anywhere up to $15,000, so that number could have gone higher. Taking those $65,000 off, then we are at $556,776. And again, just using the base number of $15,000, which is the maximum of the loan, potentially up to 37 businesses could be assisted. Now, I did mention when I was here 3 weeks ago that so far we have not issued any of those. And the main reason for this is, as you know, there has been all kinds of CARES funding coming into the county from all different sources. And depending on where they come, the variation of requirements is big. Specifically for these CDBG funds, as Cindy mentioned, it doesn't change the fact that it must assist low and moderate income individuals. In the sense of the small businesses, is with the intention of either retain or create jobs that would be made available for low and moderate income individuals that live in Provo. And there is further requirements. Typically, okay, so one of them is that any funding that we give out has a list of requirements. The two most difficult ones, specifically for businesses, and particularly at that time, or maybe even now, when they're looking for the funding as soon as possible, they must have a DUNS number. I forget what that stands for right now, but I hope that you are familiar with that, with what that is.
Dun and Bradstreet.
Yes, it has to do with Dun and Bradstreet. Anyway, so they must secure one of those. And using that number, they also need to go to the Federal System Award Management site and create, register there. Unfortunately, and maybe Sandy can tell you how the difficulties that she faces when she's working with the facades businesses. Dealing with that site sometimes is nice. Well, it's not the easiest and not the quickest. And those are particularly the issues when businesses were telling them, when I was telling them about this program, that they had most difficulty with, because we're not able to move forward until we have at least that information. But there's, another series of other requirements that also need to be fulfilled. So, knowing that and knowing that there's other funding available, I've made sure that I remain in contact with other sources of funding. And one of them has been Utah County. One of the, I think, at least this funding, it wasn't CDBG, it was CARES Act funding, but not CDBG, was administered by Mountain Land Associations of Governments. And they had a program very similar to the one that we had proposed, with much less requirements attached to it. And so that I've got a list of 267 businesses from Provo that were able to benefit, anywhere from I think the lowest loan was $1,000 and up to $15,000. But most of them, as you look at these lists, is $15,000 to $10,000 that they received, so that they could either stay in business, come back to business, or do whatever it was necessary to survive the pandemic. So that is one of the reasons why we have not used this funding. It's been a lot easier for them to have access to those sources that have less requirements, and it's easier to get them back in business than not. That's all I have. Unless you have questions, I'm happy to answer.
Yeah, so if I may. So you had mentioned something earlier that there's a knockout provision on the application if they had applied for PPP. Does that also apply to the MAG grants that were going on? So if a small business owner comes to you and they've already gotten PPP or they've already gotten the one through MAG, did that preclude them from being able to proceed with an application?
Not necessarily, because we do have to see what other sources they have used.
Right.
But they would only not be able to get the funding if they were intending to use it for the same period that they received the other funding. But if they use the funding, the period is passed, they're looking at something else, and that's where it's applicable, they would still be able to.
So is it safe to say, based on the report that you're looking at from MAG, that most of those were for 6 or 12 months ago? I mean, it seems like most of that would be for a prior.
It's all the way back until February or March of this year.
Yeah.
Yeah.
Okay.
So again, the program's still available, and we'll continue to make it available. And hopefully there'll be some businesses that have the opportunity to use the funding. I think part of the question also was asked is, what happens if we don't use this funding? How long do we have to use it? And can we use it for different things? And so we have a total of 6 years to expend the funding. So we have a little bit of time. However, by the third year, we must have expended at least 80% of that funding. So that's a little tighter deadline that we need to meet. Can we reprogram these funds to something else? Yes, as proven by when I came 3 weeks ago, we used that funding for something else. And there's a wide list of things that we could be doing, and we've been looking at how to move this funding. There's several ways in which we can do it. This being a one-time funding and not one that we necessarily applied for it, although we had to, kind of make that as well. If for whatever reason we were not able to use all the funding, it would not reflect badly on the city. It would be unfortunate that we would have to get it back, but it would not penalize us in any way. But again, we're looking for ways in which we can actively spend the funding and serve the citizens of Provo as it should be.
So just a quick follow-up. So where does a small business owner find additional information at this point if they're interested in considering?
From us, we so far, or up to this point, we don't have a specific place for them to find it. We kind of have asked the other places where they're going to go get funding, because it's easier for them to get that funding, to know, hey, there's this other resource. But where we are now, it's probably beneficial to be more proactive and let them know the funding is available.
If someone were to call though the city at this point, if someone were to call 311 and just ask, hey, you know, there's a business program, they would just be referred to you.
Routed to me.
Okay.
And they will have the information. Yes.
Perfect. Thank you.
Mr. Hardy.
This is probably a very naive question, but I'm going to throw it out anyway. We were talking earlier about ways to encourage uptake of vaccines among our population, particularly some of the populations that hasn't received the vaccine at the same levels as others, and they may fall into some of that low and moderate income. I just wondering aloud, is this some money that we might look to help with that effort? I wonder if the kind of the programs we were considering earlier might qualify for, would be eligible for this money. Anyway, I don't know if that's.
So just to make sure that I understand what you're saying is, could we use some of this funding to subsidize or fund a campaign for vaccination? Yes. And yes, seems like it would qualify. I heard part of the conversation earlier on that there were some of those populations that would qualify, and that would be an appropriate use of the funding.
Okay, excellent. So
whether we work directly with the hospital or some other agency.
I think I saw a slight nod from Mr. Parker. So just if that's something that we might look into. Great, thank you.
Okay. Is there anything else?
All right, thank you, Mr. Gonzalez.
Yep.
Any further discussion about the information that we've heard? All right, then we'll move on to the next item, which is an ordinance to amend the zone map for approximately 26 acres near the access area to Slate Canyon, and this is to be presented by Melissa McNally.
Hey, good afternoon. Thank you. We are proposing a zone change for approximately 26.11 acres on a piece of property. It's a single parcel that is at the mouth of Slate Canyon. There are no developments currently planned on this parcel, and this parcel was recently purchased by Provo City. So this zone change would only affect the city as a landowner. We are proposing to rezone it from an R110 to the open space preservation zone. This particular parcel is in the middle of the critical hillside overlay. So this would be, we feel like this would be a really good and appropriate change for this piece of land. The feedback that we received from the neighborhood was all positive and in favor of this zone change. And the Planning Commission also voted unanimously to recommend approval of the zone change. Do you have any questions for me on this item?
Councilor Ellsworth.
Yeah, was there a neighborhood meeting?
There was not.
Okay. Just worried that I missed it. And then my other question is I think the other parcel that we bought is immediately north of this. Is that right?
I'm not sure. I'm only familiar with this parcel.
Okay. Well, we bought 29 acres, so I'm just curious about the 3 acres that's missing from this rezone, and maybe it's already zoned.
I'm not sure. I can check on that if you'd like on that parcel.
Thank you. That'd be helpful.
Yeah.
Mr. Parker, do you happen to know the answer to that?
I'm sorry, Mr. Chairman, go ahead. I missed the question. Oh, if we included it in the, I'm sorry, I missed the issue. Go ahead,
So
Councilmember.
I
I'm
thought
sorry.
that we bought 29 acres and this is a
Mhm.
rezone for 26 acres.
Yes, this is a rezone only of the single family zoned portion. Not all of that parcel we purchased was single family zoned.
And do you know what the other 3 acres was
I
zoned?
think it's already in a PF for an open space. Do you recall, Gary? What's that? It's in agriculture.
Okay.
Yeah.
Okay. Well, we probably need to rezone that one as well. So
Yeah, I think
maybe
we certainly
there's some
could.
more
This was just a
information about.
focus to get it out of development potential.
Okay,
So,
gotcha.
yeah, but if you'd like, we could initiate a rezone on the other piece as well.
Thank you for clarifying that. Mr. Harding.
Thank you. I believe the road is called Aspen Loop. It's kind of that half circle. Do we know, is that a private road or is that a public road?
I think that subdivision is all public streets.
All public
Yeah.
streets? Okay.
Yeah, there are some limitations in terms of parking and so on, but those are imposed by the HOA and are managed then by the HOA, but the streets are public.
Okay. I'm just, I support this. I'll be voting for it. We've talked a little bit about, what this looks like in the future, and I really support, and, I know those things take time. And so, how we want this to develop and look in the future. And I think there's, we'll see these master plans in the future, how this is gonna look at, so we can recreate. And that's, I think, the reason why we purchased this is to kind of be able to control that. I do look though at that Aspen Loop, and it looks like, and if I remember the property boundaries or whatever, we've got homes all along there, but then where the road butted up against these other properties, there aren't homes. And it, if we have a public street there, we've invested in the infrastructure and whatnot, unless we're going to be using that land as part of the park or part of the recreation. And I'm just speaking broadly, I don't know if anyone planning is hearing or whatever, but I hope when we take a holistic look at that, we consider, does it make sense to have some residences there, whether they be single family detached or single family attached or whatever makes the most sense there. But, if we can provide some more housing opportunities for future residents of Provo, as well as have a really well done recreational area, I think that's ideal. Now, if we need that space in order to access that resident or recreational space, that makes sense. But if it's just because it just seems like there's a gap there, and if there's no public use for that, I don't see any reason why we wouldn't want some more housing units there.
So go ahead, Mr. Regan.
Okay.
Probably answer better than I can.
So as we purchased this property, some of the property was in the R110 zone. As a part of this deal in the purchase agreement, the seller was concerned about the remote possibility that the city could turn around and sell this off for development, and did not want that to happen. So we committed to rezoning the property, especially the R110, as quickly as possible into the Osprey zone. And that's why this is here before you. We did this rather quickly. The intent was to put it all into the park. So all of that park area that you see, or the blue areas, is intended to be programmed in some fashion into the park, and no development on that. And then as we plan in conjunction with the Parks Department for that area and the remaining private lands around there, those are issues that could be looked at. If on private property not owned by the city that was acquired, especially acquired in this purchase agreement, there is a possibility if those could be developed, then they would.
Okay. And if I remember, it was a right of first refusal if we wanted to move that back. And
yes, I
guess the point I think for me is if that's going to be viable, beneficial park space, great. If it's going to just be, we already have that investment of infrastructure there. If it doesn't detract from the park function, I personally would like to see maybe even, and give them the right of first refusal if they want to develop those homes there. Again, only if it's doesn't detract from the park function, and just because we need housing where we can get it. And so if there's no public reason not to, public interest reason not to, I think that would be something to at least consider when we're doing the overall planning.
And we can't answer that today because we do need to go through that process and it may be a little while.
Can I add a comment here? If I remember correctly, the area that you're referencing, there's like a narrow neck of land, if you will, and that's that 3-acre parcel, I believe. And it connects from the north end of this blue area up to that Slate Canyon drive that goes up into the canyon. And so I think this area is fairly critical for access into the city-owned property, unless we want to bring it through the skills park, the mountain bike skills park, which would require us to reconfigure quite a bit. And then to your point on the road, I was under the assumption it was private. It is public, but there are some parking restrictions there, which maybe the administration wants to talk to the HOA about, because they could have on-street parking on that road per city ordinances. But I think at the time it was not permitted. So it would free up on-street parking for users of this area.
Mr. Chair, I might just mention as well, initially, the developer of the Aspen Loop area had been collaborating with the proposed developer on this property before he acquired it. And the intent was to provide access to that new development through this further eastmost street of Aspen Loop. And again, I think there were anticipated to be 2 road accesses there, and homes would likely be built on those 2 road accesses. And so the area on the east edge of that Aspen Loop was really expected to develop in the new subdivision. That's why there's no homes on the east side there at the time, for the moment.
Thank you. All right, looks like we're finished with this item. Thank you very much. Let's move on to item number 6, which is an ordinance amending the Provo City General Plan to adopt an intent statement for the Westside development policies and Southwest area future land use map. This item is to be presented by Hannah Salzel.
Thank you. It's good to see you all again, by the way. Do you guys have my new presentation? Okay, this is the old one. Do you have the one that I sent around to this afternoon? And Leah, I sent it to you about an hour ago. We can take a sec to get this pulled up. Yeah, no rush. I've been there, no stress. So this is coming back to you. Obviously, it originated with David Harding. You all know the background for this, so I'm going to gloss over that a little bit. We took it to the Planning Commission in a study session, and they had a few questions before we took it to the public hearing. Their recommendations were things like perhaps it should apply only to developments over a certain size. Maybe it shouldn't be mandated. Maybe looking forward, we should put in images or graphics that are more relative to what Provo's looking for. A lot of residents were a little bit concerned with the graphic that was included in the intent statement because it was much higher density than what was actually being proposed. So maybe something at the appropriate density so they don't set off alarm bells. So I'll summarize also the feedback from the actual public hearing and from the Open City Hall and other letters we've received from residents. And then as far as I understand, Dave Harding, are you going to present the rest of the statement? I'll cover the Planning Commission side, but it seems silly for me to present when you're right here.
Yeah, no, that's fine. And I think we only have this scheduled for 10 minutes. So there were a couple of points that I wanted to talk about, just the process, but I think I've pretty much presented.
Yeah. Great. We can even leave it on this if you just want to scroll to the next page. That works for me. So I'm not planning on going through all of those steps of the agenda. They're there in the presentation if you want to reference them, but I'll let you do that on your time since this item is limited. Would you go to the next page? So we've checked off the first few steps in the process. This is now coming back to you after Planning Commission's recommendation. Next slide. The letters early on before the public hearing, there was some mixed support for reaffirming commitment to the Westside development policies and the land use map. People seem to support those. They're the result of a lot of compromise. but general opposition to increased density and more granular integration of housing types, which carried over to the public hearing. The residents who spoke were opposed. They don't want the neighborhood to change. They don't want property values to decrease. Landowners and developers also didn't want to be limited in what they could do with their land or how they could decide to sell it or parcel it out. There was two developers and a real estate broker who came. They said that we need more inventories. They support the increased density, but they do not support the second change integrating housing types more granular or on a more granular level because they wanted the flexibility to make that themselves. A few Westside residents also expressed they kind of felt like the Westside had become a testing ground for different policies for the city, a bit of a dumping ground, and wanted to make sure that any policy that did go through from the council was well thought out and had a lot of public input. You go to the next slide. Open City Hall feedback as of this morning. Those who opposed, we're back. Those who opposed greater density did so because, again, they wanted to maintain the neighborhood feel, preserve owner occupancy with larger homes, increase the average income, and not increase traffic in their area. Again, they opposed housing type integration. Some thought they should focus on, or you should focus on airport businesses like hotels rather than on housing. Again, they feel like that issue's kind of been settled. Also wanted an impact study and had some concerns about this coming just from one person. And one person said, maybe we should look at reconvening the Westside Planning Committee. Will you go to the next slide? Those who supported greater density did so for the typical reasons of preventing urban sprawl. They were all familiar with improving walkability, alleviating the housing crisis. They saw it as more of an equitability issue. They mentioned the granular integration less, but when it did come up, it did get votes of support. And someone lamented that we could have had a tech hub on the west side, but we have housing instead. So there do seem to be very, very polar different opinions from residents. Would you go to the next one? This is my last slide. This is the feedback from the Planning Commission. As you know, they recommended denial of the general plan amendment and encouraged the council to consider housing type integration on perhaps a citywide basis, perhaps creating a zone where a mix of housing types is not permitted as it is right now, but required. And again, perhaps only to developments over a certain size. They were of mixed opinions on whether mandating a mix of housing types was necessary or if it would simply complicate things or turn developers away from Provo. But they all agreed that we do need more homes at a variety of prices at whatever level of integration the council decides. And they just wanted the document, if it was adopted, to be very easily accessible with lots of good graphics and clear language. And that was the entirety of their recommendation. Do you have any questions?
Councilor Henley.
Yes, thank you, Hannah. I'm a little, I don't know if I didn't read it well or what my problem was, but I struggled to understand where the Planning Commission was coming from. And maybe this is for more discussion tonight, but I would appreciate more understanding of the reasoning behind their recommendation, because it sounded like they liked the idea. Otherwise, they wouldn't have recommended that we make it citywide, or did they dislike the idea? There was some ambiguity there in the report that I found a little confusing.
Frankly, there was some ambiguity in their discussion, but that happens. We were there talking about it for a long time. The conversation kind of looped and winded. I recommend watching the video if you have time, or maybe speed it up on YouTube, because it did get pretty nuanced, and I'm trying to capture the very broad brushstrokes here. They felt like one of the housing types that was really missing were moving up homes. And this is something that residents brought up too. Planning Commission agreed. We have a lot of starter homes and middle homes, but not nicer homes that families can move up to and upgrade. Step up homes, move up homes, whatever you want to call them. And the West Side might be a good place to put those because of the land, because of the residents' desire for larger lots and higher median incomes for the area. So maybe an integration of housing types would be good. They understand the benefits of neighborhood vitality and integration and diversity, but maybe the West Side is not the right place for that. Or if it's such an important policy to Provo and we do want that integration on the West Side, then maybe it's important enough that we should talk about having it everywhere. We're sort of the two different angles where that idea was supported. Hopefully that clarifies it.
That's helpful. Thank you.
Mr. Hardy?
So if I may, and again, with the time we have remaining, I have prepared a little more to discuss in the evening meeting, but I was able to attend the Planning Commission meeting, was it 2 weeks ago, 3 weeks ago?
Yeah, July 14th. Yeah.
3 weeks ago.
Study session.
I was not able to, the study session, I was not able to attend, and I haven't had the chance to go back and watch the most recent one. Even at the time when I was there and discussed, or I was there at the meeting and was able to talk with them, I think there was some confusion about what this is. And, on the report of action, they recommend denial of the general plan amendment. And I think so just from the very foundation, there's some miscommunication, misunderstanding here. This is not a general plan amendment. This is a intent statement that requests them and our planning, our planners, city planners, to develop a proposal. And that's basically what it is. It's asking them to do this. And so when they come back and say, well, we recommend denial of the general plan amendment, and we recommend in their report, they recommend that the council consider some of these things like, better graphics and, a citywide, that's almost exactly what we're asking. If we were to adopt this intent statement, it's not an amendment to the general plan. It's just letting them know that we would like them to work on this and do exactly, I think, what they're saying that they're recommending to us. So there's some miscommunication there. Another thing that I didn't catch on that meeting that I was there, in part because I don't receive the documents that they do, but they had the older draft. If you remember, there was an early draft of this intent statement after working with some other people, with several stakeholders, including staff. There were several changes made to that draft. They received the earlier draft, not the later draft. And I think that may have been where some of that miscommunication came in.
We would love that other draft. This is the only copy that staff has. So we're sorry if we passed on an old one. We'd love to see the new one.
Okay. And I apologize. I'll take responsibilities for some of that. I think it made it to council staff, but maybe not, it wasn't handed off to planning staff. And then again, I unfortunately was gone when some of this was happening, so I wasn't able to correct it. But number 3 here on the purpose of the discussion, where it says change density from 4 units per acre from net to gross. Again, there was some miscommunication, or there was confusion in there, and that started with me. I had gross and net backwards on what it meant. And so in the second draft, we made it very clear. This is not any sort of a change. This really is a clarification, because the policies could be or have been interpreted differently. There's different interpretations. So this was a clarification. This is not a change. And it was like like number 1, it's also reaffirmation on what the second committee had come forward with. And I just didn't see that written anywhere. And also we had some developers pushing back and wanting more density. And so this was supposed to be just a reaffirmation that we weren't, of what that density standard was. So any discussion that was taking place about not wanting more density or wanting more density, that's outside the scope of this intent statement. This intent statement was just to reaffirm that. So they had an older draft. There really should not be any recommendation of changes to density. If that's something that someone wants to propose, that's another can of worms to open. But
may I simply interrupt and ask a point of clarification?
Yes.
Will density, are you proposing it should stay net or change to gross?
That's a longer discussion that I was able to have with some of the staff. So what it is, and I hope I get this right, what it is across the whole area, it's to be 4 units to the area, 4 units to the acre gross.
Mm-hmm.
And what I thought was happening is we have areas that are higher density, and I thought that was coming out of like the regional sports park and things like that that are obviously 0 units to the acre. But what it is the area marked res is 4 units to the acre net, which translates to just under 3 units to the acre gross.
Yeah.
And that's how it's offset. And so area wide, it's 4 units to the acre gross. And in the res areas, it's 4 units to the area net, which translates to just under
2.8. Yeah.
2.8. And so the second draft makes that explicit.
Okay, good.
The first draft may have had some confusion in that, but yeah. So the proposed intent statement is not supposed to make any changes to that, but just reinforce what has already been decided, but not necessarily articulated, because we're still waiting for the text part of that goes along with the map, future land use map. And it's not a general plan amendment. I apologize. I've taken too much time, but the point is I think there is some confusion in there. And I actually think that our intent statement is very well aligned with what the Planning Commission recommended that we consider. And all we're saying is, yes, we want this considered. Please work on some graphics. Please work on some policies or some actual language that would do what we're talking about here.
Okay.
Any other comments or questions? Oh, Councillor Henley. Thank you.
Sorry, I forgot to lower my hand.
Okay. All right, it looks like we're done with this one until tonight then. Thank you very much.
Thank you.
We do not have a closed session for tonight. So consider a motion to close the meeting, or Brian, can we just adjourn by unanimous consent in this case? If there's no objection, we'll adjourn by unanimous consent and see you back here at 5:30 for the public meeting. Thank you.